స్టార్ట్ అయిపోయింది. The one of you ready.
Now 140 minutes.
MCQ collect பண்ணுங்க. Can submit your MCQ papers. நீ அந்த சைடு வாங்க, நான் இந்த சைடு வாங்க.
ஓகே நீ வர மாட்டியா கஷ்டப்பட்டு சேவ வச்சுக்கிறேன் hello everyone எல்லாம் போஸ்ட் பண்ணிருப்பாங்க can we start the meeting
Yes, well, actually, you are supposed to make everyone
okay,
co-host.
good afternoon ma'am, welcome ma'am.
You are supposed to make everyone co-host, no? Only then they can present.
Ma'am, we have made everyone host, ma'am. They can share the screen and
Yeah. Only you are the host. Nobody else is made co-host. Just check. Ask someone to check.
Madam, we are able to share our screen, no problem.
Yes,
Okay.
ma'am. Yes, ma'am. Thank you, ma'am. ஏன்டா இவ்வளவு கம்மியா இருக்கு நல்லா அதிகமா இருக்குமே வால்யூம் ma'am இப்போ ஓகேயா ma'am பத்மா ma'am
If I am unable to see anybody as co-host, if everybody are able to share it, fine. You can start off.
everybody is able to share madam
Problem. Then start off.
so we can start ma'am. It is 2. So welcoming you all to the 43rd city. Welcoming you all to the 43rd city pathology meet. This is the first meeting for this year, and so we start with our first case, Dr. Femela from Kauvery Hospital. Femela, Dr. Femela, you can share your screen.
Ma'am, very good afternoon, ma'am. I have already shared the PPT. Is it visible? For me, it is visible, ma'am.
It is visible.
Thank you, ma'am. Good afternoon, respected consultants, faculties, and MD pathology students, DCP students. Can we start, ma'am?
Yes, Dr. Femela, you can start.
Thank you for giving the opportunity to share this interesting case. This case is a very simple morphology-based diagnosis. It does not require ISC or high-five molecular test. Just because it is a rare diagnosis, I am presenting this. Maybe it is very simple. This case was a 71-year-old female. She presented with intermittent fever for the past 3 months, and she also had osteoarthritis. She had a loss of appetite and loss of weight. So she underwent a multi-speciality evaluation. During bronchoscopy, she was found to have nodules in the trachea and the left main bronchus. So this was the bronchoscopy appearance of the nodule. So they did a biopsy. It is very difficult to do biopsy because it was firm in consistency. So what we could receive was a very small, tiny tissue, but we could see the nodules in the submucosal layer. Here there is a defect because the other half of the tissue had the diagnostic material. So the nodules in the submucosal layer were covered by the bronchial epithelium. This nodule was nothing but a fragment of mature, that is lamellated bone tissue, which was lined by bronchial epithelium, which showed squamous metaplasia. All that we could get was this only. Like this, she had multiple nodules throughout the trachea and the left main bronchus. So this was a diagnosis of Tracheobrochiopathia, osteo chondroplastica. Very simple only, but still very rare. This is a rare condition of unknown etiology, and patients usually present in the 5th or 6th decade of life. It was first described in 1857 as ossific deposits in the larynx, trachea, and bronchi by Wilkes and colleagues. Usually, they present as submucosal nodules protruding in the anterolateral walls of the trachea and the proximal bronchi. There will be abnormal quantification and ossification, and the prevalence is estimated to be between 0.01 and 0.8%. Radiological findings would be submucosal nodules in the trachea and the proximal bronchus, and trachea may show calcification. Bronchoscopy will reveal multiple submucosal nodules in the trachea and the proximal bronchus protruding into the lumen, and it is covered by mucosa. Endobronchial biopsy may be difficult because of the hard consistency of the nodules. The various terminologies which are used in radiology to describe this lesion would be cobblestone, stalactitic cave, mountainscape, and rock garden. Histopathologically, we used to see a nodule composed of cartilage or bone in the submucosa, and calcification may be present, and they are lined by tracheal or bronchial epithelium. Squamous metaplasia is common. The complications would be tracheal stenosis and bronchopulmonary infections. Atelectasis also can be seen. So we have to differentiate it from tracheal amyloidosis or polychondritis or papillomatosis or endobronchial sarcoidosis. Sometimes if it is single, then neuroendocrine tumor also has to be ruled out. The hypotheses which are implicated in the pathophysiology of this lesion are: first one is ecchondrosis and exostosis from the lateral tracheal veins. Second hypothesis is metaplasia followed by ossification of the connective tissues. Third hypothesis is malfunction of the airway stem cells inducing neo-osteogenesis. And bone morphogenic protein 2, that is BMP2, and TGF-beta1 have been implicated in the nodular formations. That's all, ma'am, about that case. For the sake of PGs, I just included these potters. Molluscum contagiosum, showing the Henderson-Patterson bodies. Intracytoplasmic inclusions composed of viral particles. And this is a case of lepromatous leprosy, to showing sheets of foamy macrophages, and in the fight Faraco stain, the bacilli are seen, lepra bacilli. These are my references. Thank you, ma'am.
The slide that you had sent, did you include the osseous metaplastic area? I don't think so.
Ma'am, it is there, ma'am.
It is there.
It's there. This one.
Oh, it was there?
Yes, ma'am. Yes, ma'am.
Okay.
It was in multi-layering, ma'am. In the photograph, I could not capture in a single plane.
Oh.
How does it affect the patient, Dr. Femela?
Yes, ma'am. Ma'am, actually, if it is not causing tracheal stenosis or in the block in the airway, the patient will not be affected, ma'am. But sometimes it may be huge enough to block the airway, and sometimes it will result in atelectasis of that particular segment. Otherwise, it's not a problem. And the bronchopulmonary infections are common because of the ciliary function will be affected. So the patient will present with frequent respiratory infections.
What happened to your patient?
This patient, ma'am, okay, actually nothing happened. This was removed. Multiple nodules, whichever were big enough, were removed. That's all. She didn't have respiratory infections, and she didn't present with atelectasis.
Anyone else for their comments, please?
I reviewed, but I don't find this ossification there. It is only half hidden, I think. It was not very clear.
Yes, ma'am. Actually, it was
squamous metaplasia we were able to identify, but not the osseous areas. Okay, Femela, it's okay. It's a nice case. Rare.
Crossing was hard enough, ma'am, and it was bits and pieces. So a clear photograph in the small biopsy, it's very difficult because they are
okay.
In that they have to take the biopsy. It is challenging for the clinician as well. It is not like excision biopsy or a planned surgery they cannot do.
Thank you, Femela, for that rare case. And we have also reported one case, I think, few years back in Stanley. We have reported the same. We have reported a similar case. Thank you, Dr. Femela. That was a beautiful presentation.
We are ranging from 0.1 to 0.5 centimeter.
So if there are no other comments, can we go on to the next presenter? Dr. Lata from Stanley Medical College.
Am I audible, ma'am? Good afternoon, everyone. I'm Lata from Stanley Medical College. First of all, I would thank to our professor and HOD of our and Professor Martina, ma'am. And now I'm going to present a case of 65-year female who came with complaints of post-menopausal bleeding since 6 months. In MRI pelvis, it shows a complex pelvic abdominal cystic mass, and they have done cervix biopsy, which came to be as moderately differentiated squamous cell carcinoma.
Hello. The slides are not moving. It is only stopping with city pathology meet. All the other slides are not showing at all.
Ma'am, we'll check it, ma'am. This is.
You put that on slideshow, na? Oh, okay.
On slideshow, ma'am.
Ma'am, is it okay now, ma'am?
Check whether the slides are moving. Put the next one, see just whether it is moving.
Go to slideshow mode, ma.
Yeah, that is what they should have put it on that. Automatically it will go, na?
And they haven't put it in slideshow mode.
Why?
Ma'am, is it visible now, ma'am?
Move பண்ணி பாரு. Move பண்ணி பாரு.
It is visible, but you go to the next slide and see whether the other slide is seen. Go
Here
to
slide.
slideshow mode la varala, ma. Maybe you need to log off. Yes, now it is seen, but not in the slideshow mode. Yeah, it is moving, not in the slideshow mode, but full screen la varala.
Not only that, they have skipped 2 gross pictures. It's only the histology which is shown.
Start from the beginning and show all this.
Put it as start from the beginning, ma.
Yes, ma'am. Ma'am, this is the first slide, ma'am.
Second.
Yes, ma'am. This is the second, ma'am.
Okay. Where is the third?
Yes, ma'am. Is it okay, ma'am?
Varla, ma. Third slide varla.
இது படிக்கலாம்ல. மேம் இப்ப அந்த கிராஸ் பிக்சர் தெரியறதா மேம்?
இல்லையேப்பா, தெரியலையே.
Case history தான் இருக்கு. 210/225.
But if there is any problem, ask your IT people to come and help you.
So we log out and ask others to present. Ma'am, we'll stop sharing. We'll ask the next presenter. By the time we'll sort out.
Yeah,
We
we
will
are the next presenters.
Okay, ma'am. Okay, ma'am. Dr. Lata will stop screen sharing, and then Mehta has நீங்க present பண்ணலாம், ma'am. Then we by the
Okay,
time we.
okay. Thank you, thank you.
My slide is visible, ma'am.
Are you able to see?
Yes, ma'am. Take care. Yes, ma'am. The same.
Good afternoon, everyone, and welcome to 43rd City Pathology meet. So today I am presenting the case of a 59-year-old male who came with complaints of epigastric pain and retrosternal pain for 3 months. Otherwise, there was no significant history except for some hypertension and hypothyroidism, for which he was on medication. Ultrasound report showed a 2 into 2 centimeter pancreatic groove lesion, which was located in the head of the pancreas, and 2 DDs were given, pancreatitis or a mass, and CT abdomen was suggested. CT showed a well-defined enhancing soft tissue lesion in the head of the pancreas. MRCP showed a possibility of a duodenal cyst. While PET-CT, it showed a ill-defined FTG avid iso-enhancing mass lesion of around 4.9 into 4 centimeter in the head of the pancreas, and it was seen showing mild displacement or infiltration of the medial wall of the second part of duodenum. We received a Whipple's specimen. This was the per-operative picture where the Hansens process of the pancreas, stomach, jejunum, and CBD and gallbladder are marked. So we received 3 specimens. A first specimen was a gallbladder, second was a common hepatic duct lymph node, and third was the Whipple's specimen. So this was the Whipple specimen with which contained part of stomach, the pancreas, and the distal end of duodenum. So the cut surface of the head of the pancreas, showed a well circumscribed, pale white, firm lesion, which was around 4.5 to 3.5 centimeter. This was the microscopy. The local view showed a lesion which was separated by the pancreatic tissue by a thin fibroadipose tissue. This is also low power. The periphery is showing normal pancreatic acini, and this is the lesion. A thin fibrous septa is separating the tumor. And on hyper, you can see it is all spindle-shaped cells in fascicles and haphazard manner. And there was a pleomorphism and increased mitotic figures of around 12 to 13 per 10 hyperfields. And these tumor cells were surrounding the benign ducts. The ducts were not showing any dysplasia or malignancy. The spindle cells only were pleomorphic with increased mitotic figures and surrounding the blood vessels. So this was the histology of the lesion. So with this, we gave 2 differential diagnoses, whether it is a sarcomatoid spindle cell carcinoma of pancreas or an undifferentiated pleomorphic sarcoma of pancreas. And IHC was suggested for this. So the initial panel of IHC showed a negative pan-CK, ruling out the spindle cell carcinoma of pancreas, and also S100 was negative, but Vimentin was strongly positive. So with this, when we there's a nice article which showed the approach to tumor of uncertain origin. So I'll just share the flowchart of it. So if Vimentin is positive, then with the morphology and clinical features, we have to rule out certain mesenchymal tumors. So in this case, the spindle cells with pleomorphism, so we have to make, and the radiological diagnosis of GIST. So we have to rule out all these, like desmoid tumor, for which we have to do beta-catenin, inflammatory myofibroblastic tumor, for which we have to do ALK1, leiomyoma, for which we have leiomyosarcoma, for which we have to do SMA and calpanin, DFSP, for which we have to do CD34, rhabdomyosarcoma, GIST, and vascular tumors. So these are all our DDs. And with this, we went ahead with the next panel of markers. So that showed CD117 and DOG1 were negative, which ruled out GIST. Desmin was occasionally focally positive. Myelin was negative, beta-catenin negative, alkaline negative, CD34 negative. So only the positive was SMA, calpanin, and Desmin, which was focally positive with a KI of 50 to 55%. So with this, this was the IHC pictures, biomentin, SMA, and KI67. So with this, we came to a final diagnosis of pancreatic leiomyosarcoma, grade 2. So a few points about this pancreatic leiomyosarcoma. It is a very rare tumor, and it is, but it is the most common of the stromal tumor of the pancreas. It is postulated that it originates from either the wall of the intrapancreatic vessels or from the smooth muscle cells of the pancreatic ducts. So positive staining for SMA, caldesmon and desmin will assign the mesenchymal tumor to the myogenic subgroup and excluding the myofibroblastic tumor. The presence of tissue necrosis, mitosis and pleomorphism will confirm the presence of malignancy. And the grading system, as we all know, we use the French Federation of Cancer system, that is tumor differentiation, necrosis and mitosis. So to conclude, diagnosis of pancreatic leiomyosarcoma, it relies on the interlacing spindle cells with a positive IHC and malignant features like pleomorphism, mitosis, and necrosis. Operative management with complete resection of this tumor is the gold standard treatment. Now moving on to the spotter.
This was a 75-year-old female. Of course, query MDS was described in the requisition, but this was a known case of myelodysplastic syndrome, and she had a recurrence of dyspnea and a pedal edema. So that is why they did a bone marrow, and that was the peripheral CBC and peripheral smerilla. CBC findings: hemoglobin was 4, WBC was 4.7, and neutrophilia was there. Platelet was adequate. Okay, so bone marrow aspiration and biopsy both were done, and that is the aspiration. I'm sure all of you can appreciate the binuclear form of megaloblastic type of maturation of the RBC precursors. You can even up also you can find megaloblastic type of a morphology. Platelet clumps you can see here and there. And again, this is a megaloblastic RBC precursors and one in mitosis up, one in mitosis, and all the others are all megaloblastic maturation. But and this is of course a dysmorphic type of a megakaryocytes. So I'm sure all the postgraduates and the budding pathologists would have known that no more it is called as a myelodysplastic syndrome. It is called a myelodysplastic neoplasm. So the terminology has changed, and when I was a postgraduate, we used to classify MDS into unilineage dysplasia, bilineage dysplasia, and multilineage dysplasia. Even that terminology is now become obsolete. And here, of course, this you can say that it can be called as a bilineage dysplasia because of the dysmorphic megakaryocytes as well as the dysmorphic megaloblastoid change in the RBC precursors. The biopsy was the one which is a little bit mind-boggling, I would say, because in the it was, for the diagnosis of myelodysplastic syndrome or myelodysplastic neoplasm, peripheral pancytopenia, the packed marrow in an elderly person, one should always consider the possibility of a myelodysplastic syndrome. When you have a packed marrow with a peripheral pancytopenia, please consider the possibility of MDS, and that is what you are finding now. You find that it is a very fairly a cellular marrow, and there are some pigment deposits which you can appreciate. And apart from that, apart from the usual the trilineage type of cells in the intertrabecular area, you find these clusters of some kind of cells which you are not able to categorize. There is one cluster here, one cluster there, and another cluster here. Yeah, so many clusters are there, and we were wondering what it could be. We searched the literature, and see, this is the literature picture, exactly what we are seeing in our own slide. Now, this is called as an abnormal localization of immature precursor cells in the bone marrow. which is usually seen in MDS. You can compare the picture of our slide as well as the picture which is given in the literature. I just want to know whether any one of you have come across this ALIP, abnormal localization of immature precursor cells. Not only in MDS, you can see them in acute leukemias also, especially in the myeloid. Actually, the precursors are rare and are found localized near the endosteum and consist only of 1 to 2 cells. Whereas here you find them in the intertrabecular area with the clusters and aggregates of more than 3 or 5. Here, in fact, it's more than 5 cells. And the importance of clinical significance of this is the worst prognosis associated with MDS. And in the bone marrow sections of patients with acute myeloid leukemia, cells similar to ALIP were also defined as ALIP-like clusters. And this again is very important because remission, during remission, if it is reported like this, see, normally they do a minimal residual disease, but they usually do a bone marrow. We also get bone marrow biopsies and aspirates to know whether it is a minimal residual disease, though flow cytometry is the gold standard for a minimal residual disease. But if you find in an acute leukemia, especially in AML, if you find these kind of presence of ALIP-like clusters during remission, then you can always tell the clinician and alert them that they can be associated with the early relapse of the disease. So I thought that this is not a very common occurrence, and many people who now, leukemia is actually almost every day we see the leukemia, almost every day. And, so I thought this is a very, very important point. So I thought I will just share all these pictures with you. And as far as the pancreatic tumor is concerned, we ourselves were not very sure of a carcinoma sarcomatoid type because, nowhere we could find any evidence of an epithelial malignancy. But then actually one of our differential diagnosis was GIST. It had that storiform pattern and typically like a doubt of fibrosarcoma, it had the features of a GIST, but then, IHC confirmed the diagnosis of a leiomyosarcoma. Questions?
Okay.
Ma'am, that was a primary leiomyosarcoma of the pancreas.
Yeah, it is primary. Actually, there was infiltration into the duodenum also. I don't think
This is a male patient.
I know. Oh, you thought it was a female patient?
Ma'am?
Yeah, no. You asked whether it was a primary.
Yes,
You
ma'am.
thought
Yes,
it was-
ma'am.
Yeah, so okay. Leiomyosarcoma metastasizing to pancreas in a female, I think it will be in the report. We have yet to see that. Anyway, this was a male patient, but even then, it is not a very common lesion. Actually, we were also quite surprised when we had when Vimentin was positive. See, any stromal tumor or any connective tissue tumor, Vimentin will always be positive. But then the other markers for Leio were strongly positive, and so that was a very, very rare finding. And we are presenting, and we are not only presenting, we are also publishing this case. It's under preparation by Impana.
What is அதுக்கப்புறம் PET scan ஏதாவது பண்ணாங்களா madam? What is
See, PET scan was reported as query GIST.
This thing of MRCP was just.
MRCP, yeah.
PET showed a lesion in head of pancreas.
Yeah.
So it didn't.
They didn't say any diagnosis. They are very non-committal. They will always say correlation with HPE. It's a mass lesion.
Retroperitoneal lesion extending on to pancreas?
Pardon?
It was not retroperitoneal sarcoma extending on to.
No, it was well defined within the pancreas.
It was in the head of the pancreas, infiltrating the second part of duodenum to the wall of the.
No, I'm just asking, is it not duodenal malignancy getting onto the pancreas?
No, Padma. No.
That's what their lady was just in radiology, man. They thought it's a gist which was extending to the pancreas.
That is a more common thing, so that's why I.
We also thought of that, Padma, but then it was clear cut. Did you see the section in which we showed rising from the pancreas, stromal tissue with a benign ductal glands, and then the stromal showing all these pleomorphic features? So it was primarily a tumor arising in the pancreas.
So the stomach, duodenum were free, madam.
It is not free.
All that was P.
Yes, ma'am. So it's a primary leiomyosarcoma, which is very rare. Yes, ma'am.
And by ALIP, any comments? Anybody
that
come across? Where is Chandramauliswari? She is the one who is dealing with so many leukemias, no? Has she come across any such lesion in the bone marrow biopsy?
Madam, I think Chandra madam has not logged in.
Sita,
ALIP we
Hello.
keep seeing in our
Hello,
bone marrow
Sita.
biopsies.
What, Padma? Can't hear you.
In our bone marrow biopsies, we keep seeing ALIP in MDS cases.
You also see.
Yes, ma'am. It is seen.
You have
It's one of the
reported.
diagnostic.
You have reported?
ALIP we keep seeing in bone marrow biopsies, and then we proceed with the molecular and IHC and all that. Only then we release, ma'am.
Okay, CD34 should be positive if it is a immature precursor cell.
Yes, ma'am. It is one of the diagnostic clue. Based on this, we will go ahead with the other modes of confirmation.
Okay. Since it was not discussed, I thought I should at least discuss this so that everybody will be aware of
It is a practical
this.
thing, ma'am. It is a very good thing. Practically, it is very important only.
Yeah, that is why I said, because it gives you a clue whether it is going to be a relapse or whether it is going to have a worse prognosis. All that
Yes, ma'am.
can be a prognostic indicator. So that is why I thought I bring it in the forum.
நான் பேசணும்னா எனக்கு தரணும் அந்த பத்மா இப்ப பேசணுங்களா
பேசுங்க மேடம் எழில் மேடம் பேசுங்க மேடம்
Sita, thank you so much. It's such a rare entity.
Stopped.
Practicing pathologists always. Are you hearing? I'm audible. Am I audible?
பேசுங்க மேடம் பேசுங்க நல்லா கேக்குது
But voice is interrupted.
ஆமா இங்க கிளியராவே இல்ல எனக்கு பேசவே
Your
முடியல
voice is interrupted. It is interrupted.
Okay, but I just want to congratulate you for a good presentation of this. Both are quite interesting. And markers are always helpful for difficult cases. You have proved it. Nice.
Ma'am, any other inputs? Or can we go on to the next case, ma'am?
Yes, ma'am.
Ma'am, thank you, ma'am. Thank you, Dr. Impana, and thank you, Sita madam, for that 2 cases, ma'am.
Thank you.
Ma'am, can we go on to the next case? Dr. Lata sharing her screen. Presenting my case and second presentation.
Ma'am, is it visible, ma'am?
Visible, lot of echo. I think you are on multiple devices.
Good afternoon, ma'am. Now I'm going to present a case of 65-year female mom who came with complaints of postmenopausal bleeding since 6 months. In MRI pelvis, the patient is having complex pelvic abdominal cystic mass, mom, and they have done small cervix biopsy, which we have given it as moderately differentiated squamous cell carcinoma. And after that, we have received a radical hysterectomy specimen, mom. And this is the specimen which we got hysterectomy. In this, a gray white lesion was seen in the endocervical region.
Slide is
which
not
of
moving,
1
madam.
cross-
Slide is not moving, madam. Please check. Your slides are not moving.
Yes, sir.
Are you presenting with your mobile phone or with the device?
Laptop,
Lap-
mom.
Okay. Yeah, now it is moving. Gross is seen. Yeah.
Yes, mom. Is it
Now we are,
changing?
yeah, it is moving.
Thank you, mom. And this is the specimen which we got. In this, we are seeing a gray white lesion which is present in the endocervical region of size 1 cross 0.5 centimeter. And this is the in the second picture also we are seeing the gray white lesion. And this is the complex cyst which we got, and this is of size 30 cross 20 cross 10 centimeter. And on cut surface, it is a unilocular cyst, and serous fluid was let out. In the cyst wall, we can see the small nodules, which are of ranging size from 0.3 to 2 centimeter in diameter. And this is the H&E picture of cervix, in which the epithelium shows the complete full thickness of dysplasia. And this is the picture with nest of tumor cells.
Slides not moving again.
And these are the nest of cells which are present in the stromal tissue of cervix. And this is the 40xp in which we can see the tumor cells of round to oval squamous polygonal cells with moderate eosinophilic cytoplasm. And this picture we can see the lymphovascular invasion. And this is the one more picture in which we can see the lymphovascular invasion of the tumor cells. And this is the ovary which was attached to the uterus, and it shows the features of endometriosis, the stromal tissue of endometrium. And these are the H&E pictures of complex cyst. From the cyst wall, we have taken this, and this cyst shows the squamous epithelial lining. And this was with the complete full thickness dysplasia. And these are the H&E from nodules which are present in the cyst wall, which shows the tumor nest cells within the stroma, and it shows the keratin pearl formation. And this is the one more picture showing the tumor nest within the stroma of ovary. And this is the high power view of tumor cells. And these are the tumor cells which shows the vesicular nuclei, and this is atypical mitosis also seen. And we proceeded with the IHC markers in which P16 came in the cervix bits, in which P16 came to be positive, and P63 was also positive, P40 also positive, and we done GATA3 also. In ovary, in the complex adnexal cyst also, we have done P16 which came to be positive, and P40 which it also came to be positive, and GATA3 to rule out the malignant runners. So it came to be negative. So these are the markers which we have done P16, P40 and P63 in the cervix which came to be positive, and GATA3 was negative. And in right adnexal cyst, in P16 and P40 came to be positive, and GATA3 came to be negative. So we given it as in cervix, moderately differentiated squamous cell carcinoma grade 2, and in right adnexal cyst, metastatic deposits from the cervix, and in the left ovary endometriosis. And we given the staging as PT1A2 due to stromal depth of invasion of 5 mm, and M1 as according to AGCC classification, when METS to adnexa or uterine serosa, it is considered as M1. So we given it as stage M1. So ovarian metastasis from cervical carcinoma, from squamous cell carcinoma, it is only of 0.4 to 1.3% due to its rarity. Now I have presented this case. The roots of cervical cancer spread to the ovary are mostly direct extension or lymphatic and hematogenous spread, or through transtubal migration. And previously, there was a case report in which superficially invasive cervical squamous cell carcinoma metastatic to ovarian endometriotic cyst wall. In that patient was 45-year female, in which 2-year history of ovarian endometriosis, and the patient has a malignant stratified epithelium in the cyst wall. So they underwent a hysterectomy, in which they got a superficially invasive squamous cell carcinoma of the cervix. In that patient, they have done HPV test, which came to be positive. And in that case also, there is no involvement of uterus and other side ovary and both fallopian tubes as of our case. These are my references. Thank you.
Ma'am, your inputs, ma'am.
Other
Only one
organs
thing
are
that
free,
was
yeah?
ceremony.
Rectal involvement and other things, parametry, normal. Yeah, okay. Color?
Ma'am, yes, ma'am.
Other organs, rectum, black, all that.
All that was normal, madam. Rectum, all the other organs were not. It's only the cervix and the ovary, madam.
Metrium, that is the
Ovarian
Parametrium was
sulfate
free,
bleeds
madam.
was there. Ovarian sulfate bleeds was
vaultum bitter, cervical vault.
Ovarian surface was normal, ma'am.
No, surface.
okay. Other ovary was also not endometriosis only, right?
Yes, ma'am. Yes, ma'am.
இது ஹெமட்டோஜீனஸா லிம்ஃபாட்டிக்கா போயிருக்கும். Hello.
Yes, ma'am. You're online.
Oh, yeah. Gross cut surface also not able to side. It's a microscopic focus or grossly you identified anything from the ovary?
Cross of the ovary, serosal surface was normal, madam.
உள்ள cut surface was it significant previous before histopathology? During grossing, did you find anything abnormal?
Ma'am, once more, ma'am, I'm not able to.
Did you find anything abnormal before, during the grossing in the ovary, I'm asking?
Ma'am, serosal surface was normal, madam. On the mucosal surface, or nodular areas, whitish, gray, white nodular areas was there, ma'am.
Mm-hmm.
And cervix.
How is she responding? Is she responding to treatment now?
Ma'am, she's on post-op observation, madam. She's responding to treatment, madam.
Okay.
So the cervix shows the growth, and from there it's straight to the ovary, madam. Ovary, the serosal surface was normal, and the mucosal surface shows great white nodules, madam. The same histology both here in the cervix and in the ovary, madam. And the markers were done. P40, P63 was positive.
Achha.
Sorry, P40 and P16 was positive, ma'am.
சொன்னீங்களே.
So, literature refer பண்ணும்போது squamous cell. Ma'am, okay, ma'am. If any other inputs, then we can go on.
Presented very well. Congratulations.
Yes, ma'am. Thank you, thank you, Dr. Lata. Here we go on. Is Dr. Nisha ready from KMC?
Yes, ma'am.
Then you can share your screen. Welcome, Dr. Nisha.
Thank you.
Dr. Nisha, can you share your screen?
Yes, ma'am. 1 minute.
Share your screen. Share screen. Zoom.
Able to see, ma'am? Hello?
Oh, your screen
Hello?
is not seen. Your screen
Yes,
not
ma'am.
seen. Ma'am.
Share screen available. அடுத்தவங்க பண்றாங்க எனக்கு.
Krishnakumar, sir?
Yes.
Sir, you can share your screen if you're ready, sir. Good evening, sir.
Good evening, madam. I'll just share.
Yeah, welcome, sir. Nisha, by the time you can just sort out the issue.
You are able to see it?
Yes, sir. Yes, sir. Your screen is visible and you're audible, sir. We can start.
Yes, good afternoon, seniors, consultants, and my friends. These are because for many of the pathologists, they don't know Dr. Thambaya, my teacher, and Professor Patrick Azudin, my teachers. I always make it a point to talk with gratitude to my teachers. First case from Chennai Skin Foundation. Lady aged 50 years with a yellowish nodule on the face. Biopsy was done. It was a well circumscribed mass, cystic component, had a blue staining cells and sebocytes. The the germinating component was more than 50%. The sebocytes were less, no atypia. We called it as a sebaceoma. So usually we recommend, but in the senior people, I am not aware people do it or not. It was signed out as sebaceoma. But anyway, we have to do the mismatch repair proteins. You can send the block to private labs where they do the immunohistochemical panel and they also do the PCR. Case 2 from Chennai Skin Foundation, man aged 70 plus, had pigmented. He came for some other problem, and then Dr. Muruksundaram noted this and said this is the major problem. So biopsy was done. Incisional biopsy, the ulcerated. Incisional biopsy shows a nest of atypical melanocytes in the epidermis, showing a pagetoid pattern. The dermis, there was not much dermal involvement. A lot of inflammatory cells and melanophages were seen. And patient had the finger removed and he was referred to Global Dr. Raja, where the sentinel node was negative and the patient is doing well. So this was signed out as superficial spreading melanoma. Third thing, lady had a nodule in the nose. This is from Chennai Skin Foundation, Dr. Molluscum. Biopsy was done thinking it is a basal cell carcinoma. Here you find normal sebaceous glands with a lot of basaloid cells. No connection to the epidermis was seen. You find this well basaloid component with peripheral clearance and with a basal membrane-like material. So one thing, whether I was looking at a tricholemoma, but anyway, I gave a report as a basaloid tumor with a sebaceous differentiation, no cracking artifact, not much atypia, clearly completely excised it. I told them I was not able to subtype it. So here I just gave a general report as a basaloid tumor with not much atypia, and so this I will see what seniors tell. There are many types of tumors which can have a sebaceous component, like sebaceous adenoma, hyperplasia, carcinoma, BCC. So usually we must try to subtype the sebaceous tumors. This is very important for prognostication. This from US, a lady had a young girl. Mother was concerned. The girl's hair color was turning brown, and so I asked them whether the girl used any coloring agent. She said no. So then she sent me some more photographs. This looked like a protein coloring malnutrition to me. I shared the images and discussed with Dr. Sundaram. And then he says that this we see with the L-cysteine deficiency, especially then I understand the girl was on a vegan diet, tried to lose weight, and vitamin D levels were low. So I asked her to consult the nutrition in US, and she is on vitamin D supplement. And she's also got some nutrient supplement from Walmart, and the mother is giving the girl the nutrient supplement. Within 3 to 4 months, the hair color will come normal. I'll update you on the follow-up. Usually, we don't do biopsies, but if the hair breaks are there, we can always do a hair shaft analysis, histopathology sections to look for any damage to the cuticle. So this girl had this hair color change because of vegan diet, and L-cysteine was low. Case 5, this is from Bombay. This my classmate's brother had gone to Vietnam and Bangladesh, and then he had multiple nodules in the back. And so they were very concerned, and biopsy was done. This is the images she shared me. And these are the papules near the occipital area and in the back. Histopathology was done, and somebody reported as atypical dermal lymphoid infiltrate and suggests immunohistochemistry. So my classmate was very concerned and sent the slides to me. So this was a report given by outside. So then we had the section sent. What I saw in the slide was you find epidermis unremarkable. You find dermal perivascular lymphocytic infiltrate and periacrine lymphocytic infiltrate with plasma cells. Very occasional eosinophils were seen. There was not much vasculitis. And so I said two possibilities, either is Lupus Tumidus or insect bite reaction. And I don't see evidence of mycosis, fungoids, and all those things. So the brother was put on doxycycline and antihistamine, and the entire lesion subsided within 2 weeks. The thing is, every time we think of, we see a lymphocyte infiltrate. If we do immunohistochemistry, we are not going to get help from immunohistochemistry. We can get a very confusing pattern. Case 5, this is from Chennai. Somebody came with this slide, and they wanted immunohistochemistry for rural lymphoma. I saw the slide. It was a spongiotic eczema. I told them, sir, we don't need immunohistochemistry for this. You can ask a dermatologist to review after a couple of weeks. This is because every week I get a couple of slides to rural lymphoma from the city clinicians. So immunohistochemistry is not going to help us. It is clinico-pathological correlation. I have shared the slides. Whole lot of inflammatory dermatosis can show only CD8 infiltrate. So we must be very, very careful not to succumb to immunohistochemistry. And even we do this T cell receptor gene rearrangement. Even lichen planus can show monoclonal or oligoclonal bands. So we must be very, very careful in doing immunohistochemistry and clonal studies in inflammatory pathology. Next is this is from Dr. Reddy from Apollo. This man was aged 40 years. He had some skin problems in the lower abdomen. So the first biopsy, they sent the slide to me, and they had reported as figurative erythema. And then I said, figurative erythema, I am not comfortable. Let me see the patient. The patient came, and he showed this zostriform distribution of the. It was very painful nodules. Something. When I touched him, he was wincing with pain. I showed there was involvement of the subcutaneous fat. Then I called Dr. Reddy and told him, Dr. Reddy, you have to go for a deeper biopsy. So the patient went back to Reddy, and then he did a deeper biopsy. And he brought the slides from Apollo hospitals. You find a granulomatous inflammation with a lot of inflammatory cells. Once again, granuloma. And you can find this a lot of inclusion bodies, many LD bodies were seen. And this was reported as LD body by Apollo, and Reddy was very worried whether this is also correct diagnosis. I told them, Reddy, it is correct. I agree with Apollo report. It was leishmaniasis. So this was a leishmaniasis. I'm seeing leishmaniasis after quite some time, so I thought it is very interesting. So every case, the clinical pathological correlation is very, very important. Next is this child had after the 2 years completed, child had a tonsure, and then hair was not growing at all. Child was put on a tofanicity for more than a year, and they thought it is alopecia totalis. Child was put on tofanicity syrup for more than a year and no response. So they were very concerned, and the case was shared with me. Then I discussed with Dr. Molluscum, hair expert. It is congenital hypotrichosis and not alopecia totalis. No biopsy was done. A child was referred to the counselor for because managing this is very challenging. Because here in congenital hypotrichosis, there is no cure. It is only a cosmetic solution. And alopecia totalis will respond to JAK inhibitors. If we do histopathology, you can find the hair follicles absent or malformed. But in alopecia totalis, you can find lymphocytes and miniaturization of the follicle can be seen. Because it was very classic case of congenital hypotrichosis, biopsy was not done in this case. This also I shared. So whenever you get this hair loss, always discuss the cases with your hair expert so that we make a correct diagnosis. This is from Delhi. They thought it's a fungal granuloma, multiple nodules around the eyelid. So when I saw the slide, it is a malignant tumor. You find this downward expansion of this cells going deep into the dermis, and areas of necrosis. I told them it is a malignant tumor. The way it looks like a high-grade squamous cell carcinoma or a porocarcinoma. Since you folks, they thought fungus, we sent it to all path lab for immunohistochemistry. Immunohistochemistry came as adnexal neoplasm, highly infiltrative. So I put it as porocarcinomas. Porocarcinomas is known to can have intra-vegetoid spread-like pattern, and the satellite nodules can be seen in porocarcinomas. And this can metastasize, so patient needs aggressive treatment. Then this case from Delhi once again, ulcerated nodule in the lower lid. So concern was whether it's a pigmented basal cell carcinoma. I saw the slide, and then you find this nests of cells looking like nevus. But what was very surprising is usually in nevus, we find the larger nest and the top and smaller nest in the lower. At the maturation, here the maturation was very reverse. Then I know this was nevoid melanoma. Once again, see this small nest and larger nest. This is absolute reversal of polarity. I told them this is a nevoid melanoma. And so once again, because Lal Path Lab is close to Shroff Center, they sent to Lal Path Lab. HMB45 was positive. SN was positive, and Soxton positive. So the report came as nevoid melanoma. The patient has got no pegyroid extension, and frozen section is being done for margin clearance. So this is for students' purpose. Nevoid melanoma, this is the second case I'm seeing. You must be very, very careful that you just miss it as a nevus and go away. And we don't want it to come as a nevoid melanoma by some of the pathologists. Be careful. Next is this is from Salem. Now, this gentleman had a non-healing ulcer going here for 3 or 4 areas in the skin with scarring, So there was no diagnosis. Somebody grew Pseudomonas and microbiology at Salem and Tirupur. So they sent the sample to me for opinion. And I also, as usual, I asked them for skin photograph, and they shared me some skin photograph. You can see the scarring. The surgeon tried to rebreathe the ulcer. So this sort of scarring is there, can be seen in many disorders. Then we went to histopathology. Once again, see the scarring. Histopathology, you find epidermal hyperplasia. In the dermis, you find a neutrophilic abscess in the center. Then you find multinucleated giant cells. In the periphery, you have lymphocytes and plasma cells. So with this ulcer and this sort of pattern, we would like to go for atypical mycobacteria, fungal ulcers and all those things. Fungus is negative and TB was negative in this patient. And then the only thing left was some entities which I have seen taught by Professor Yesidian. This entity called superficial granulomatous pyedoma. It is a variant of pyedoma gangrenosum, and that can go as kilbiform scars for months and years. Response well to doxycycline. So once again, see the neutrophilic abscess with the multinucleated giant cells. It's again multinucleated giant cells and neutrophilic abscess. So I gave a report as a superficial granulomatous pyedoma. I told them, please do all these investigations like ANCA, PANCA, CNCA, ANA, and please rule out vaginous granulomatosis. Then after a week, he said PNCA is very mildly positive. So he said he will talk to the rheumatologist to consider whether to consider it or not. A patient is on doxycycline. He is doing well. That's what I understand. So the rheumatologist told to ignore the PNCA mild positivity now. This is a tabular column to know between classic pyedoma gangrenosum and superficial granulomatous pyedoma. It is chronic indolent. It's rapidly progressive. Pyedoma gangrenosum is very, very painful, necrotic. And usually you don't find granulomas in classic pyedoma gangrenosum. In superficial granulomatous pyedoma, you find granulomas. Usually the treatment is topical or systemic. Systemic association is very, very rare. In classic pyedoma, they have all this inflammatory bowel disease, rheumatoid arthritis, vagus, etc. Next is this patient, this lady came to my consulting office telling that she has got these furuncles on the face and abdomen not responding to antibiotics. And she also had weight loss. I touched that parotid, that face nodule was very firm. Then she showed me that umbilical also nodule is there. Then I sent it to my friend Subha for a biopsy. Because you know that umbilical, during our surgical posting, we have read umbilical Sister Joseph that deposits can present as umbilical nodule. So biopsy, when I saw, I was very concerned because it is a malignancy. It is a malignant tumor cells arranged in a storiform pattern. Mucin was positive. So I gave a report as mucin secreting adenocarcinoma from the umbilical nodule. Screened for ovarian. She had some 10 years back. She had teratoma operated at Stanley Medical College. Spoke to Ramachandra and sent to Dr. Manivasagam at Ramachandra Medical College 10 days back. I'm yet to get follow-up from Dr. Manivasagam. So any biopsy, any nodule in the umbilical is always better to get a biopsy done to rule out metastatic adenocarcinomas. This is once again, it's from Anderson lab. The slide had come. This image is for representative purpose. Patient had oral ulcers, and the diagnosis was bullous pemphigoid. So the consultant was concerned because the patient did not have any skin lesions. So they brought the block to me, and the sections were taken, and you find a subepidermal split. And it was a subepidermal split, means it goes with the bullous pemphigoid. And then you find this eosinophil. So nothing, the diagnosis is correct from the histopathology point of view. But the consultant had also done serum bullous pemphigoid antibody was high. But looking at only the oral lesions, he also had a laryngeal stenosis. So he said the diagnosis is benign mucosal pemphigoid, which is challenging to treat because it can produce ocular surface scarring, and patient must be treated aggressively, even though the patient now does not have any ocular surface scarring lesions. I told the consultant to refer the case to a cornea surgeon who specializes in ocular surface, and also to the ENT surgeon, because already she had got stenosis. So we must be very, very clear to differentiate a benign mucosal pemphigoid from bullous pemphigoid, because benign mucosal pemphigoid tend to scar. Classic bullous pemphigoid does not scar. So this is something we, as a pathologist, we must be aware. Just it is not enough. We tell a diagnosis of bullous pemphigoid. If you can subtype, it will be good from the management point of view. That's what take-home message is. We need to differentiate a bullous pemphigoid from mucosal pemphigoid because of the scarring. And this from referred by Dr. Subba, dermatologist in Mylapur. Patient has rheumatoid arthritis and is on leflunomide. Is diabetic, is on dialysis, had multiple nodular swellings on both legs for 3 months, has got pain. So they thought of a deep fungal infection. They shared the photograph with me. So even looking at it, I thought this could be one of those deep fungal infections I see in transplant patients like pyelohypomycosis. So biopsy was taken, and you find this florid pseudoepitheliomatous hyperplasia, and fungus is negative. Fungus is negative. Then you find this dermal inflammation. You find this abscess. A lot of abscess were seen in that endophytic growth of the squamous cells. Once again, see this neutrophilic abscess. A lot of abscess was seen. And in the dermis, there were inflammatory cells, mostly eosinophils and neutrophils, some macrophages and giant cells. Here, some areas you can find a vague palisading pattern with the peripheral neutrophils and histiocytes. Once again, some sort of vague palisading pattern with neutrophils and inflammatory cells. The same thing showing this neutrophil collections in the dermis. So with this, so I thought of two possibilities, whether it is a neutrophilic palisading granulomatous dermatitis and a differential diagnosis pyodoma vegetans, which can happen with the patient with rheumatoid arthritis. Fungal infection is negative, and also Cal protectin levels were normal. So patient was referred back to the rheumatologist. He is an oral colchicine, and they thought this could be fungus, but we told there is no fungus. Patient is an oral colchicine and is responding to the treatment. That's what I understand from Dr. Subba. Lesions have dried up and is referred back to the rheumatologist to take care of his the arthritis problem. I'll keep you updated about this case because it's very when I discussed the case with my teacher, he said, could this be perforating dermatosis of Kirley's disease? Usually in perforating dermatosis like Kirley's, and you find the lesions are keratotic and very small. You don't get this polycytic granuloma in perforating dermatosis. So I told Professor Yusri and sir, from the histopathology point of view, I cannot think of Kirley's disease which happens in diabetics. Then this was shared it come from UK. This is a boy in US, and he had a pigment. He's around 14, and biopsy was done. And the case was finally reported by Professor Philip Leboit at UCSF. I never got the histopathology images. They sent me 10 pages of molecular printout and asking me whether I can comment on this. I told them that my knowledge in spitzoid nevus is not very high. And I understand there's no reliable markers, immunohistochemical markers to differentiate atypical Spitzer melanoma. And when we looked at the report, from UCSF, the professor has applied, Leboit has used FISH, PCR, NGS, CGH, whole lot of data to analyze this case. This was the analysis from UCSF. They used the cancer panel. No mutations were seen. Gene fusion, the child did not have gene fusions. Chromosomal aberrations were looked for this case. But what I understand is this was something very important. When I shared the information at MD Anderson, my friend, she told that this is very interesting. That CDKN2E gene, there is some deletions on that. So they have to remove the lesion completely and look at this regional node for any deposits. So finally, I told, who am I to comment on procedure for the uses of report. Our knowledge is not much great. So, but since there is CDK into deletion, we need to monitor the boy and ask them to completely remove the nevus. So that's the status. Why I brought this case? Because now in US and other places, we don't see much melanomas in our country. But this pizzoid nevus, reed nevus, I have seen 2 cases. From some people working in embassy had brought the slide. I openly tell them that we need to do molecular profiling. There are panels to do, gene expression profiles to do, cytogenetics to do. So I tell them, you please send the blocks to St. John's, London, or the US. And I don't, in my lab, I don't have expertise to do all those things. So I want to know like how there are others in the, my seniors, what do they do when they see this pizzoid type of nevus? Like how do they tackle these cases? That's why I brought this case. Then this is man age 64, had according to from the consultant, he had a melanocytoma in front of the optic nerve for many years. Suddenly it started growing. So FNAB was done, and FNAB, I told it is melanoma. So they removed the eye. So here, this is the enucleated eye showing retina. And these are the tumor cells which does not have pigmentation, and the melanophages in the periphery. Higher magnification, you see tumor cells arranged in fascicles surrounded by the pigmented cells. This is bleach showing large polygonal cells. Many of the cells don't have prominent nuclei, but one small cell here has got epithelioid-like cell having a prominent nuclei. Then further sections show this prominent nuclei. So this is melanocytoma transformation to melanoma. So we were justified in removing the eyeball. And there is also invasion into the sclera by the melanoma cells. The question is, now they want to prognosticate it. Usually when you want to prognosticate it, there are 2 groups. If you are practicing in the US, we do gene expression profiling. In the US, there is a company called Castle Diagnostics. We can do biopsy of the pigmented melanoma, send it to Castle Diagnosis in Seattle. They do this gene expression profiling and subtype into class 1, 1A, 1B, non-metastatic. Class 2, it is a metastatic melanoma, so that we can counsel the ophthalmologist, counsel the patient. But in Europe, they do more of chromosomal aberration, and they go into this lumpo prognostic algorithm. I was initially using I was asked to use this polyclonal antibody Santa Cruz to do the backbone immunohistochemical staining. Normal nevus cells will have this backbone immunohistochemistry. It will be there in the nucleus, but there is going to be a backbone mutation when the backbone immunostaining from the nucleus, it becomes more cytoplasmic. That time we can tell it is a class 2 melanoma. But the problem is the polyclonal Santa Cruz is not it's not CLIA certified and not meant for diagnostic reporting. So I have recently, for the past 1 year, I stopped doing this Santa Cruz polyclonal antibody based backbone in my lab. So I spoke, this helps because this melanoma we can stratify into low risk and high risk. High risk means they can enter into immunotherapy, surveillance, etc. So using chromosomal aberrations, we can stratify. Usually we do monosomy 3 and disomy. If the melanoma has got monosomy 3, it enters into high risk melanoma. If there is disomy, it is a low risk melanoma. Usually many of these melanomas have liver metastasis within 5 years. So I spoke to Dr. Sarah Copeland, program director at Liverpool. They do this Liverpool ocular oncology lumpo program, where they look at the tumor diameter, tumor height, cell type, and they also do this chromosomal aberration there. We are not able to get the probes for monosomy 3 and disomy here. Initially, Zymet lab was giving this probe, where I used to do on the sections by Kish chromosome in situ hybridization technique. But what happened, Zymet probe, they said for your single person, single lab, we cannot distribute the probe. So we don't get Zymet probe. So I spoke to Sarah Copeland and I told to the patient also, they were able to afford, please we'll send the cell block to Professor Sarah Kuplan, and she'll be able to do the study in her lab and put the algorithm and able to prognosticate for her father. So this how people want to prognosticate melanoma, but because of the costings and the challenges, we were not able to do. And many times when the melanomas are so pigmented in the Indian population, even the gene expression profiling, the QC does not pass. There's another problem MedGenome has faced. In Europe's and Caucasian tumors, it is not, the pigmentation is not so high. So they're able to do the gene expression profiling. I would like to know the audience thought on this. Then this is an abnormal nodule in a boy.
KK sir, KK sir, sorry to interrupt. Sir, 15 case போதும் sir.
முடிஞ்சாச்சே சரி 1-2 more தான்.
அப்படியா? ஏன்னா you have many interesting cases. அதை discuss பண்ணாலே நமக்கு.
No. Okay, madam, I'll stop here. I'll not stop here.
Sorry.
No problem. Can I stop it?
We can put it in the next. Sir,
Yes.
Questions, sir.
Yes, madam. I'm open for any discussions.
Yeah. Sir, that was a beautiful array of cases from infections to benign neoplasms to malignant neoplasms. You are talking about that child who lost his hair after tonsuring, no, sir? So you said the loss of hair follicles, congenital hypotrichosis.
Hypotrichosis.
So that means first time the child had enough hair. You showed the photograph also.
Yes.
So that time, what is the explanation there?
So what I spoke to Dr. Murugasundaram, he says congenital hypotrichosis, after the first tonsure, the hair does not grow. Usually it is like that, it seems. That's what I understand from them.
First time, the hair follicles all that.
First time it is that, then the hair follicle gets dysplastic, it does not grow. So instead of biopsy, they usually use a trichogram, it seems. Looking with the trichoscopy and trichogram, they are able to make a diagnosis of congenital hypotrichosis. That is not respond to tofanisertib. That's the reason the child had more than 1 layer of tofanisertib syrup and there was no hair growth. So he told the child's mother to stop giving tofanisertib to the young child because it has got many side effects, and went for some cosmetic covering of the scalp.
Okay, sir.
This is not progressive alopecia.
Madam, after some time, the child's entire hair scalp will be bald, madam.
But initial hair growth is so much.
Usually, I understand. Initially, the child will have hair like that. After the first tonsure, then the hair will not grow.
I think we can think twice before tonsuring the children nowadays. Because there's a real point to be taken care of. So especially girls.
This is the first time I'm hearing this, usually every family, they will always say before the next birthday, we should go and give, the tonsure the head. But Krishnakumar, this is something, it is a little undigestible, Krishnakumar, because the child is born with so much of care and then suddenly no hair, it is genetica, it should, he should not have had hair
at all.
So many children we have seen during birth, they have very less hair. I've seen almost not exactly bald, but almost no hair. Then after that, they grow hair, and that is what it is something which I cannot digest, KK.
No, actually, some of them will have a loss of hair, baldness, male type of baldness will come for female, and males, the growth of hair will be low for some. And this is very, we have to delve into some more literature and read. And one more thing, Krishnakumar, your first case, clinical diagnosis, clinical picture, more looking like a trichoepithelioma, and sebaceoma was my first diagnosis.
It is sebaceoma, madam.
And second, the third case, clinical the picture doesn't fit in your diagnosis. I feel it is sebaceous adenoma. Other things is the spongiosis, all that. Leishmaniasis is a spotter, and equine poroma, the ninth one also, there is no nucleoli. Site is or not also, I'm not
No,
accepting it.
that is a first, that's occurring porocarcinoma, not poroma. Porocarcinoma.
அதுதான் நீங்க சொல்ற போரோகார்சினோமாக்கு நியூக்ளியோலை ப்ராமினென்ட்டா வரணும். Site is not I'm accepting. It doesn't look like that.
Lila, அது கொஞ்சம் it had features of malignancy only, ma'am.
Yeah. Agreed. Well,
Site is
agreed.
not-
Most of these cases, we were also able to decipher because, you know, we are all seeing all this adnexal tumors. Leishmania was excellent. Cutaneous leishmaniasis was an excellent slide.
That is a very beautiful slide.
Very beautiful slide. And spongiosis, spongiotic dermatitis, all that we have seen.
எல்லாமே
But
நல்லா இருக்கு.
some of the terminology, of course, we may have to refer the literature before we sign out the report. See, some of the, you know, because dermatopathology is a special subject. Anyway, by the way, Krishnakumar, what happened to your blue book?
So 2025, madam, it is coming. This year only it is coming, madam.
Okay.
Sir, upon the Vietnam, Bangladesh, and that lupus tumidus, special, it's a special to it. It's just an abroad trip. You just wanted to say an insect bite.
That is tick. It's some tick bite in Vietnam, something, madam.
Oh, the tick bites are more common in Vietnam, sir.
ஆமா, அவர் வந்து அங்க போய் வந்து கீழே படுத்துட்டு இருக்காரு. Yes, கீழே படுத்துட்டு இருக்காரு. Then so maybe some tick is bitten because with the doxycycline everything clear.
Okay, sir. Okay.
Luckily, we escaped. We had been to Vietnam and Cambodia. We didn't lie down on the floor. So
you want that vitreous aspirate, the histopathology has come, Dr. Vadarmati?
Yes, sir.
And the vitreous aspirate when I put on the pathingla, query, medullary epithelium, the histopathology has come and I put the images also. You want me, so I can talk about that case alone. It will be interesting for madam and all of them.
I don't think you have a time.
Okay,
we'll have it in the next one.
Sir, KK, sir, that was a beautiful array of cases. Because there are 3 more participants to present. Can we do it next time, sir? Please,
Sure, madam. Sure, madam. Sure.
So anyway, that was with the pictures and the histopathology. That was super. That was a very nice presentation. So thank you for enlightening all of us. Thank you, sir. Thank you so much. If there are any more inputs, we'll wait, or we can go on to the next case. Dr. Kavita from Lister Metropolis. Can you share your screen, please?
Yes, ma'am. Screen is visible, right, ma'am?
It's visible, Kavita, but only one slide is there.
Kavita, your screen is visible. You can proceed.
Yeah, okay. So, very good afternoon, everyone. I'm Dr. Kavita, consultant pathologist from Metropolis. I'm going to just tell about a rare sinonasal mass. So, this case we received from, it was like a 43-year-old African male who presented with nasal obstruction. The symptoms which he had was like nasal obstruction, which was there for past 3 months, which like increased gradually over a period of 3 months. And on and off, he had some epistaxis along with like altered smell sensation. So on clinical examination, it was like a non-tender, smooth, non-ulcerated polypoidal mass in the left nasal cavity, and radiology showed like a well-circumscribed, highly vascular mass in the left nasal cavity, which was extending into maxillary sinus. So the patient underwent endoscopic sinus surgery. Tumor was removed without any complications. The tumor was firm, reddish brown, and it was highly vascular. Tissue was sent for histopathological examination. So histopathological gross, what we received was like multiple dark brown to pale brown soft tissue, which was in aggregate measuring 3 x 2 x 0.9 centimeter. And microscopy, there was like nasal mucosa, like underlying there was a fairly circumscribed neoplasm, which was like spindled to fusiform stellate cells, which was predominantly arranged like around the vascular channels, and focally it was in sheets in short fascicles. So this is the histopathology images. Like, but we thought like in histopathology, we thought it could be solitary fibrous tumor and some low grade smooth muscle tumor, and then we proceeded with immunohistochemistry. And in immunohistochemistry, we did a panel of markers, of which only beta catenin was positive and TLE was positive and CD99 SMA was patchy positive. All other markers turned out to be negative, and CD34 was patchy positive. All other markers which we were run were negative. And the Ki67 was low, it was around 2 to 3%. So this is the immunohistochemistry picture, which was this is the beta catenin, and the one which is on the right is TLE. So coming to classification of nasal tumors, it is broadly classified into 4 subcategories: nasal and amatomas. And amatomas, there are 4 amatomas, and respiratory epithelial lesion, which has sinonasal papillomas and carcinomas. Then mesenchymal tumors. So under mesenchymal tumors, there is a 4 entity. One is angiofibroma, second one is sinonasal glomangiopericytoma, biphenotypic sinonasal sarcoma, and chordoma. And other sinonasal tumors such as ameloblastoma, adamantinoma, meningioma, and olfactory neuroblastoma. So this case was found to be sinonasal glomangiopericytoma. So a few things about this sinonasal glomangiopericytoma. So it's a very rare tumor which arises from this perivascular cells in the sinonasal tract, and it is associated with CTNDV1 mutation. It is 1% of all sinonasal tumors. It has a female predilection, and it is commonly present as a unilateral nasal cavity mass. In our case also, it was an unilateral nasal mass. And less than 5% of cases can present as a bilateral nasal mass, and it occurs at any age. Pathogenesis of this is recurrent missense mutation at exon 3 of CTNNB1 gene, which inhibits a degradation of the beta catenin. So what happens is beta catenin gets accumulated, and which in turn causes upregulation of CCDN1, and there will be an overexpression of cyclin D1, which becomes the oncogenic drive to form this tumor. So the common differential diagnosis was some smooth muscle tumor, synovial sarcoma, solitary fibrous tumor, meningioma, and schwannoma. We have done all the other markers to exclude these differentials to come to a conclusion of sinonasal glomangiopericytoma. So coming to treatment part, excision via endoscopic sinus surgery is treatment of choice, and since being a benign nature, no other adjuvant therapy is required. And coming to prognosis part, it has an excellent prognosis post excision and minimal risk of recurrence and metastasis, and incomplete excision may lead to recurrence of the tumor. So coming to conclusion, the sinonasal glomangiopericytomas are rare, benign tumor with distinct histopathological features. Symptoms can mimic other sinonasal masses, making accurate diagnosis crucial. So this complete surgical excision remains the treatment of choice. So thank you.
Dr. Kavita, can we see the histopathology once again, the pictures,
Yes,
please?
that is
Yes,
what I want. Was there any perivascular hyalinization was there?
Yeah. See, actually, when you see the histology, you can make a diagnosis of a vascular tumor of hemangiopericytoma.
Yes,
That was what I was thinking. When I saw the slide, I thought it is definitely a hemangiopericytoma. And your endocrine markers were positive, right?
Negative. Synaptophysin was negative.
Yeah.
Negative, ma'am.
Why?
It was negative only.
No, it was written positive in your discussion. Synaptophysin, you put that slide? Synaptophysin and...
TLE and...
No. You see, you show me that.
Oh, yes. Actually, it was negative.
Chromogranin and synaptophysin were positive.
No, negative only, ma'am. It was negative.
And statics is also positive.
Negative, ma'am.
Somebody has typed it wrong and you have not
positive. CD34 is positive for her.
Yeah, it was patchy positive. And only CD34 was positive, and beta catenin and TLE was positive.
To be really frank, I don't think so much of IHC panel is necessary for this tumor. You could have made a diagnosis even with an histopathology. Because it was, I felt it was very, very classical that you had perithelium-matous arrangement and the cells arising outside, the vascular channels. So actually, I thought it was the hemangiopericytoma. Anyway, I'm surprised that in Africa you get so much of history. From the African case, you have
Yes,
so much of history. I'm surprised.
Yeah,
Very nice.
post evaluation, sometimes we ask before releasing, ma'am.
Very good. Excellent.
Any other inputs?
Yeah, that hyalinization around the vessels should be there in a glomangiopericytoma. Was it present in the case?
Yes, ma'am, it was there, ma'am.
So, Dr. Kavita,
Did you appreciate
just tell us what are the positive markers and the negative markers.
Positive markers
highlights
were
of
only CD34, CD34 and 99 were patchy positive, ma'am. And apart from that, TLE and beta-catenin were positive. SMA was patchy positive. All other markers like PAN-CK, chromogranin, synaptophysin, STAT6 were negative.
Okay, Dr. Kavita.
Then call it as hemangiopericytoma like tumor of the nasal cavity photogram. It is otherwise glomangiopericytoma, but you could have put it like this.
Okay, ma'am.
Because of the pattern diagnosis.
Okay, Dr. Kavita, thank you for that nice case. And can we go on to the next presenter, Dr. Nisha from KMC?
Yes, ma'am.
Lepromatous arrangement in the chapel. Start. Welcome.
Good afternoon, everyone. Before going into my presentation, I thank my HOD, Dr. Jamila ma'am, for giving this opportunity. My case presentation is on a bilateral ovarian tumor with a peritoneal spill. It's a double trouble in shape and spill, as it is a bilateral, and we had also peritoneal fluid positive cytology. Here is a short history. So 47-year-old P2L2, not sterilized, had complaints of lower abdominal pain for 2 months. The imaging was done. MRI shows a bilateral solid and cystic lesion with multiple septations and papillary projections. The size of the left adnexal mass being little bigger than the right, and the impression of bilateral Loratz 5 was given. And with the serum markers, except for CA125, which was raised to 274 against the normal less than 35, the other two CEA and CA199 was normal. And with the clinical diagnosis of bilateral adnexal mass and complex ovarian cyst, they proceeded with a staging laparotomy. The uterus and the cervix was grossly unremarkable, and we received the ovaries like this. The right ovary, the external surface of is smooth, and except for few nodules here, and the left ovary a little bigger than the right, and its surface shows multiple papillary projections. Cut surface, both the adnexal mass were partly solid and partly cystic, with solid component more than 50% in both the ovaries. Some multiloculated cyst and the serous fluid was let out, and there were also numerous papillary projections seen inside it. Microscopy, we can see the papillary architecture here, non-hierarchical, and tubulocystic pattern with dense eosinophilic secretions inside it. And we also had a small adenofibromatous component. On high power, we can see the beautiful hobnailing of the cells where the nucleus project into the lumen of the tubules. There were also few eosinophilic hyaline globules seen. The mitotic activity and atypia is very low. Peritoneal fluid, they also show a cluster of atypical cells having moderate cytoplasm and hyperchromatic nuclei exhibiting mild to moderate atypia. And we put high NAPSIN A, which to be negative, and P53 showing wild type staining. And with the above findings and with the carcinoma, PTNM classification, we also had the omental deposits showing similar features as the ovaries. So we gave the staging as PT2B and FIGO staging as stage 2B as a intrapelvic peritoneal tissue was involved. A small few points on clear cell carcinoma. It's an epithelial tumor with incidence of less than 10% among all the ovarian cancers, with a higher prevalence in Asia and Japan, and the bilaterally, and it's a tumor of occurring in 5th to 7th decade, and endometriosis being an important risk factor. It can present as an incidental finding or it can present as a pelvic mass. It's the most common tumor, and it's also have a peculiar feature that it can present as a paraneoplastic manifestations like hypercalcemia and venous
Dr. Kavita, your voice is breaking. Dr. Nisha, your voice is breaking, Dr. Nisha.
Microscopically, it is typically unilateral, but it can be bilateral as not. Yes, ma'am. Yes. Pattern seen or tubulocystic, papillary, and solid architecture. The papillary course, the stromal hyalinization is a characteristic feature in the papillary architecture pattern. And because of the clear cells, because of intracell cytoplasmic glycogen deposition, it's PAS-D positive. The nucleus are monomorphic and mitotic activity remains low. And sometimes the intracellular mucin can be seen inside the cytoplasm, which gives an targetoid appearance. IHC, it shows a strong and diffuse positive for epithelial markers like CK7 and EMA. And it also shows positivity for NAPSIN A and HNF1 beta. NAPSIN A being specific, it's positive only in about 80% of the cases. Negative markers of WT1, ERPR, AFP, which helps in differentiating other epithelial and germ cell neoplasms. And P53 usually shows wild type of staining. Sorry. The differential diagnosis to be considered with a papillary architecture and clear cells are the germ cell tumors, especially yolk sac tumor and dysgemnoma. Yolk sac tumor, we have the papillary architecture, hyaline globules, hobnailing, all can present both in clear cell carcinoma and yolk sac tumor. In yolk sac, AFP will be elevated, but not in clear cell carcinoma. And glypican 3 and AFP immunohistochemistry will be found to be positive in yolk sac tumor. In dysgerminoma, we have the monomorphic pattern, but it resembles the solid type of clear cell carcinoma. But here we have the brisk mitotic activity and intratumoral lymphocytic infiltration will be there. And IHC panel will also help in differentiating. The next differentials to be considered is the high-grade serous carcinoma because of the papillary architecture. And in high-grade serous also, there can be focal clear cell changes. So in high grade, there will be marked pleomorphism, mitotic activity will be very high. With IHC, WT1 and NAPSIN A, they help in differentiating between the two, where the NAPSIN A will be positive in clear cell carcinoma and WT1 and ER will be positive positivity. And the next differential to consider is the endometrial carcinoma with secretory changes. So there also we can have a papillary architecture, but it is looks like a glandular crowding in back-to-back arrangement of glands. And the squamous nodules, when that is glycogenated cells, it looks like a clear cells. So with the help of IHC, WT1 and PR, NAPSIN A, these three markers will help to differentiate between endometrial carcinoma and clear cell carcinoma. The other tumors to consider are steroid cell tumor because of the clear cytoplasm. So, steroid cell tumor, the tumor size will be of small, well circumscribed, and the gross it's typically in yellow in color, and the nuclear features will also be low-grade nuclear features. Next is the stroma ovary, where the thyroid follicles resembles the tuberocystic pattern of the clear cell carcinoma. Here, the extensive sampling should be done in case of stroma ovary as that may be teratomatous components. And thyroglobulin IHC will help in the differentiating. And final differential to consider is the metastasis from clear cell RCC. So with the help of CD10 and CK7, we can differentiate between the clear cell RCC and the clear cell carcinoma of the ovary. In clear cell RCC, CD10 will be positive and CK7 will be negative. Whereas in clear cell carcinoma, CD10 will be negative and CK7 will be positive. Take home message. We presented this case because of its bilateral incidence is very rare, and endometriosis not necessarily be present in the ovary. It can also present in the other extra pelvic sites also. In this case, we had an adenomyotic foci in the myometrium. So long-standing endometriosis can lead to has the risk of developing clear cell carcinoma. These are my references. Thank you.
Thank you, Dr. Nisha.
Yes,
So what is the incidence of bilaterality of the clear cell tumors of the ovary?
It's a 8 to 10%, ma'am.
8 to 10%. So
what is the connection between the long-standing endometriosis and clear cell carcinoma? I don't understand.
Unopposed estrogen stimulation can
that need not be specifically relating or leading to a clear cell. See, unopposed estrogen activity can lead on to so many things, right?
Yes.
But why specifically clear cell carcinoma? That is what I wanted to know. Is there any kind of study which has been focusing on the association of an endometriosis and a clear cell? See, so I don't know. I have not heard about it. That is one point. And second point, you have mentioned so many differential diagnoses and so many other tumors of the ovary. But what clinches the diagnosis in a clear cell is your hobnail, which you have beautifully brought out.
Yes, ma'am.
See, when you have a clear cell carcinoma, when you see the hobnail, that's it. There is no other second opinion on any of these tumors.
Okay.
You see, when you have such a clear-cut hobnail appearance, you need not have a clear cell cytoplasm at all. But when you have a hobnail appearance, definitely it is a clear cell carcinoma. So that highlight, I would like to stress this point for the sake of the postgraduates and the young pathologists. Okay.
Okay, ma'am. Thank you, ma'am.
Thank you, madam. Thank you, madam, for the point. Because we were searching for clear cells, but it was not there actually, this case. So, but even the hobnailing was seen only in 1 or 2 foci.
It is why I felt that I should stress the importance of hobnail appearance.
Yeah, because occasionally only 1 or 2 foci we were able to find out that hobnail, which was a clue to the diagnosis. Yes, madam. Thank you, madam. Thank you.
Okay.
Thank you, Dr. Nisha, and thank you, Jamila, madam, for that nice case. And can we go on to the next presenter, Dr. Gauri Manohari from MMC?
Yes, ma'am. Can you hear me, ma'am?
Yeah. We can hear you. You can share your screen.
Yes, ma'am. Is it visible, ma'am?
Yeah.
Okay. So, myself, Dr. Gauri Manohari. I'm an assistant professor in MMC, ma'am. So the case we are going to discuss.
Dr. Gauri.
Yes, ma'am.
On the screen, konjam keezhe irangi irka mari irukku. Can you just we can only partly see your screen.
It's okay, Valar. It looks okay, Valar.
It's look okay, ma'am. Okay,
Yeah.
okay.
It's okay, ma'am.
Okay. Please proceed, Dr. Gauri.
Yes, ma'am. So we had a 19-year-old female patient, ma'am. She presented with features of pancytopenia. The clinical symptoms she presented with on and off fever and occasional bleeding from the gums, ma'am. The peripheral smear showed dimorphic anemia with leukopenia and thrombocytopenia. No blasts were seen, ma'am. Bone marrow aspiration was done. She was admitted in hematology department, and it yielded only dry tap, ma'am. And imaging wise, we could see only hepatosplenomegaly. In flow cytometry, there were no blasts detected. So we got a bone marrow trephine biopsy, considering their clinical suspicion was either it should be an acute leukemia or it should be an aplastic anemia. But in trephine biopsy, what we could see was the replacement of the bone marrow, normal bone marrow histology with this non-cohesive sheets of large cells having pleomorphic nuclei, vesicular nuclei with abundant cytoplasm as well. They showed indentation, grooving, and multilobation. The normal trilineage hematopoietic elements, we could not see anything. It was drastically reduced, but there were some reactive lymphocytes, few eosinophils and neutrophils. So with this histology, the reticulin also showed grade 2 fibrosis. So with this histology, the differential diagnosis first we thought were acute leukemia, though the morphology does not suit well, but we have to exclude acute leukemia. Then any aggressive lymphomas, like anaplastic large cell lymphomas, or whether it could be a metastatic carcinomatous deposit. Thinking about the young age, whether it could be a metastatic germ cell tumor or a histiocytic lesion. So we added a panel of markers to rule out acute leukemia, and CK to rule out metastatic deposits, CD3 and 20 to rule out any aggressive lymphomas, 15 and 30 to rule out germ cell tumor as well as Hodgkin's, and CD68 for the histiocytic lineage. So by from the above markers, we could see only CD68 positivity in both the large cells and the background reactive histiocytes. The pan-CK was negative. CD3 and CD20 were taken in a few of the reactive lymphocytes in the background. CD34 was negative. So the other negative markers were CD33, MPO, 15, 30, and TDT as well to rule out acute lymphoblastic leukemia. By this time, the PET-CT was done for the patient, which showed uptake in liver and spleen, but they could not proceed with any biopsy from the liver or spleen because the patient was very sick. And they asked us to add further panel and to come to a somewhat diagnosis. The next panel, considering the CD68 positivity and referring the blue book, and with this highly pleomorphic morphology, we thought of some histiocytic or dendritic lesions. So we added the markers such as CD163 for histiocytic sarcoma, CD21 for follicular dendritic cell sarcoma, CD1A for Langerhans cell sarcoma, X100 for follicular dendritic cell sarcoma again, and Ki67 to looking for the proliferation. So this is what we got. From the above markers, we got CD163, strong membranous and cytoplasmic positivity, and Ki67 with a high proliferation index. S100, CD1A, and CD21 turned out to be negative. So thereby ruling out Langerhans cell sarcoma, interdigitating cell sarcoma, and follicular dendritic cell sarcoma. So the diagnosis was a histiocytic sarcoma. So the summary will be a young female presented with pancytopenia and hepatosplenomegaly, a dry tap with flow cytometry showing absence of blasts. Bone marrow trephine shows non-cohesive large pleomorphic cells with marked reduction in hematopoietic elements. Cytoplasmic positivity in CD68 and CD163 with high proliferation index, and negative for the other tumors, which shows large cell morphology. So histiocytic sarcoma is a very rare and aggressive tumor. It is classified under histiocytic and dendritic cell neoplasm in our WHO 5th edition. Some cases may be associated with lymphomas, T-ALL, mediastinal germ cell tumors, etc. So it is very essential to rule out the coexisting other lymphomas. And mostly it is localized in the nodal and the extranodal sites, bone marrow being very rare. Coming to the molecular genetics, it shows genomic alterations in the MAPK pathway involving the genes of the KRAS, NRAS, and BRAF family. Or if it is associated with any other leukemias or lymphomas, it can show that corresponding translocation. So according to the Blue Book, the essential criteria to diagnose a histiocytic sarcoma is non-cohesive large cells with abundant cytoplasm, with variably pleomorphic neoplastic cells having reniform, grooved, and indented nuclei, and it should show staining for 2 or more histiocytic markers. In our case, we added CD68 and CD163. So these were the differential diagnosis. Langerhans cell sarcoma, this is also a very rare neoplasm. It can also show non-cohesive sheets of highly pleomorphic cell, but it should show CD1A positivity. And this is the interdigitating dendritic cell sarcoma, but this mostly has a spindle cell morphology, and it is mostly nodal, and it should show positivity for S100. And follicular dendritic cell sarcoma, mostly it will show a spindling morphology, but sometimes it can show a pleomorphic morphology. But it is very, very rare to see in a bone marrow. Mostly in the nodal lesions are very common. And it should show CD21. So this way we have ruled out the other dendritic sarcomas. And this is one study from the Blood Journal, the journal called Blood, in which they have done a 14-year study from 2000 to 2014 study, in which they have seen 159 cases of histiocytic sarcoma, mostly presenting in the GIT, spleen, and in the node. Bone marrow being a very rare site, constituting only 7% of the cases. So to conclude, histiocytic sarcoma, since it lacks definite disease-defining clinical, laboratory, and molecular features, it mandates a broad phenotypic panel. And since it is associated with other lymphomas, it is very essential to rule out other accompanying lymphomas and germ cell tumors. So applying the WHO criteria and correlating with the clinical details makes the classification of the dendritic cell sarcomas or the histiocytic lesion possible. So thank you so much for giving this opportunity. Thank you.
That was a nice case. Did the patient have any lymph nodes?
No, ma'am. No, ma'am. She doesn't have any lymph nodes. Only hepatospleenoma, PET-CT uptake in the liver and spleen, ma'am.
No lymph nodes at all?
No, no, ma'am. No, ma'am. She don't have.
Central nervous system, lung involvement, all that was any.
No,
was anything
No.
done, Dr. Kauvery, or any other investigations?
Investigation, CT thorax was done, ma'am. Ultrasound abdomen was done. After releasing the preliminary report as malignancy, they sent the patient for PET-CT. PET-CT was done. Apart from the uptake in liver and spleen, there were no other lesion, ma'am. But we could not biopsy those liver and spleen side because of her illness. So we cannot substantiate whether it is the primary lesion, primary histiocytic sarcoma of the bone marrow, or it is a metastatic lesion from the liver or spleen, ma'am. That we could not substantiate, ma'am.
Was there any lytic lesions of the, what were the bones involved?
Not the bones, ma'am, only the liver and spleen.
No. Bones, you said bone marrow involvement.
Bone marrow was done, ma'am, but there was no uptake in the bone marrow also, ma'am. It was routinely done to rule out acute leukemia or aplastic anemia.
Because of the pancytopenia and dry tap, they did the bone marrow.
Yes, ma'am.
Yeah, that's okay. Bone marrow biopsy was done. Okay.
So the patient did not have any lytic lesion of the bone and all?
No, ma'am. No, ma'am. She doesn't. And she succumbed to the illness also, ma'am.
Yeah, because it's one of the very aggressive type of a lesion. And the whole bone marrow was involved, right?
Yes, ma'am.
More like a metastasis when you see the H&E.
Yes,
you always think of a METS, rather than, because metastatic deposits in the marrow can definitely produce pancytopenia in the peripheral smear.
Okay.
Moreover, the pattern was sheets and sheets of cells, ma'am.
Yeah.
It was they didn't have any pattern. It was just the marrow was full of infiltrated by those type of atypical histiocytic cells.
Yeah.
And H&E.
And highly pleomorphic. I could see that.
Very pleomorphic. So only we thought whether it was histiocytic or atypical histiocytes. We went in those markers as the first choice of us.
Very nice case.
Yes, thank you. Thank you, ma'am.
Thank you, Dr. Kauvery, and
thank you,
thank you, Swaminathan sir and Padmavati madam, for the nice case. And any other inputs, ma'am? So thank you, ma'am. Thank you, Sita ma'am, Ariel ma'am, and all others for the inputs. And so we have finished. We have come to, that was a final presentation, and we have finished on time. So we started at 2 and we are finishing at, this is the first city pathology meet for this year. We'll meet in May. And thank you all.
May is the hottest month. You want to meet in May? May is a holiday month, right? Most of you will go on a holiday, no?
Ma'am, okay, ma'am. We will see the conditions.
Yeah, but then July we have the Tamil Nadu.
That's right. Yes, ma'am. Yes, ma'am. This year is packed here. Okay, ma'am. Okay. Okay, ma'am. We'll see the feasibilities, ma'am.
Yeah, okay.
As we come near, we'll see the feasibility. Next
Okay.
month also is loaded with CME, Stanley.
Yeah, it's too much.
Yes, ma'am. Yes, ma'am.
Super saturated.
மூச்சு விடவே நேரம் விட மாட்டேங்கிறீங்க.
So, ma'am. Okay, ma'am. Thank you, ma'am.
Thank you.
Thank you, Eril, ma'am. Thank you, Sita, ma'am. And thank you, everyone. And
Bye.
thank you,
Bye.
all the
Bye.
presenters, for the wonderful presentation. Thank you. Thank you.
Yeah. இதை ஆஃப் பண்ணணும். அன்பழகன் எப்ப பார்த்தாலும் இந்த ஒரு பச்சை இல்ல இங்க இதை போட்டுட்டு தான் பண்ணணும். போல இன்னும் இருக்கு பாருங்க. இந்த பச்சை இருந்தா இருக்குன்னு அர்த்தம். நீ பச்சை போகணும். Squamous differentiation போட்டுடலாம்.